Good evening, dear colleagues, ladies and gentlemen, friends. A warm welcome to all of you. Thank you for joining us tonight on this webinar, From Tabloids to Reliable Scientific Evidence, where we're going to delve into the safety of incretin-based therapies. My name is Dr. Khadija Hafid. I'm a consultant diabetologist based in the United Arab Emirates. And it's a real honor to be joined by Professor Alex Miras, who's a professor of endocrinology at Ulster University. So these are just a few disclaimers before we get started. And these are my disclosures. What the agenda looks like, we will have a discussion around the safety and try and debunk all the myths that are around injectable incretin-based therapies. We will then allow for a Q&A session whereby you can type in your questions in the chat box, and then we will have a closing and a conclusion at the end of the webinar. So our meeting objectives are really to address the concerns that we all have regarding the clinical profile of the GLP-1 receptor agonists. And we hope that this will assist us in understanding some of the recent scientific evidence on the safety of injectable incretins. We do have some housekeeping rules. We encourage you not to take any photos or videos during the meeting, and not to post anything on social media. So, from tabloids to reliable scientific evidence, let the journey begin. With me, as I said, is Professor Alex Miras. These are his disclosures. And what I'd like to do is probably start off by asking Professor Miras whether we should, for our patients that are on the injectable GLP-1 receptor agonist, have any concerns about pulmonary aspiration when they're going through any sort of general anesthesia or sedation. What are the risks, and are there any recommendations that we could, use in order to mitigate those risks? So over to you, Professor Miras.
Thank you, Dr. Khadija. That's very kind of you to have me with you today. So, what I will be doing is going through the best available evidence that I could find in all of the topics that we're discussing with you today. So, it is uncommon for aspiration to take place in people that are taking these medications around the time of surgery. As you'll see on this slide, a number of cases have been described to the Pharmacovigilance Risk Assessment Committee of the European Medicines Agency. So it's a very uncommon occurrence. What is more common is that when people are having procedures like, say, upper GI endoscopies, for example, is that they do have some residual food there, which makes the procedure more difficult. Something similar can happen in colonoscopies. So there have been a number of small publications from committees that have given recommendations as to what can be done to avoid those small risks. Here I have the reference of a group of colleagues from the UK that have decided to advise that these medications should not be stopped throughout the perioperative period, looking at the benefit versus harm. The American Society of Anesthesiologists were first to produce some guidance on this, and they recommended stopping GLP-1 receptor agonists that are daily on the day of the procedure, and the weekly ones to be stopped 1 week before the procedure. Now, I will tell you where my personal practice lies at the moment. I would say that stopping a medication, a weekly GLP-1 medication on the day of the procedure, I think probably makes us feel better, but actually does very little to the risks of the procedure. Because if we follow the rule of high half-lives, it would take about 5 days or so to get the medication out of someone's system. And the same should theoretically apply to the weekly medications as well. You're going to tell me now if we stop medications for 5 days or 5 weeks in particular before the procedure, certainly in people with type 2 diabetes, that may start causing issues with glycemia, for example. So what my compromise in my practice is to advise that the daily GLP-1 receptor agonists should be stopped for 5 days before the procedure, and the weekly ones that are more commonly used these days should be stopped for a full 2 weeks before any procedures that involve a general anesthetic or deep sedation. And having done that in the last few months, I must say that I haven't had any problems with regards to procedures being cancelled or being problematic.
Excellent. I think I would agree with all that you've said, and that has been our practice as well. To try and make sure that the patients are not off their medication for too long, as to allow them to have a deterioration in their glycemic control. So that's a very pragmatic approach to this question. So then the other thing that, we've heard a lot of noise about is really around thyroid cancer and the exposure to GLP-1 receptor agonists. What are your thoughts on that?
Throughout this session, what I would like to remind everyone in the audience are two things. that GLP-1 based medications, as I call them, is a family of medications that we have been using to treat diabetes for the last 18 years. So they are certainly not new. So everything that we discuss should be in the context of that. The second point to make is that when it comes to the treatment of obesity with these medications, there is another treatment that we have been using for the last 60 years, and we have learned a lot about that, and that is bariatric surgery. So I don't think we should be reinventing the wheel here to a certain degree, and I hope that my answers follow from the very long experience that we've had, both the use of these medications and from the learnings from bariatric surgery and its own recognized complications. And I think with the example that will become more clear. So there has been noise about thyroid cancer. The noise was initiated, unfortunately, more than 20 years ago when these GLP-1 based medications, it doesn't matter which one was tested, were associated with either hyperplasia of the medullary uh, T cells of the thyroid or with adenomas and carcinomas. And that was in rodent models of disease. In fact, in some experiments, there was no carcinogen. So as a result of that, what we're observing now is a legacy of initial findings. What I want to make clear is that in none of the randomized controlled clinical trials for any GLP-1 based medication has there been a signal for any form of cancer, including thyroid cancer. However, in the last 12 months, we have had some publications that have caused a little bit of anxiety, and this is one of them. This was from the French National Healthcare Insurance System database. It was specifically for people with type 2 diabetes that were given either GLP-1 based agonists or DPP-4 inhibitors. And those patients were matched with up to 20 control subjects when it comes to age, sex, and length of diabetes. Let me take you through the results here so that we go through this step by step. What you'll see here is that there is a just about statistically significant increase in the risk of any form of thyroid cancer and with GLP-1 based agonists, so that is by about 22%. It then goes up to 58% between years 1 to 3, and then 36% over the first 3 years of exposure. So the first thing which is puzzling and doesn't make a lot of sense is that despite an increase in the exposure of of patients to these medications for more than 1, 2, and 3 years, actually the incidence of thyroid cancer goes down. That doesn't make a lot of sense. Mhm. The second thing to mention is what we call notoriety bias. So we all as physicians are much more likely to report a cancer if we have got it in the back of our heads that GLP-1 receptor medications may cause a cancer. And that artificially increases the rates of cancer to the point that rather surprisingly, you see that these rates are about 3 to 4.6%, which is a highly unusual rate for any form of thyroid cancer in the population. So that is this phenomenon of notoriety bias. Also in this study, two more points to make. The confounding effects of other medications used by these participants, by these patients, and the confounding effect of obesity itself was not accounted for. And that could be a confounder because we know that obesity is associated with a high risk of any form of cancer. So these are some of the limitations. And the final point to make on this study is that they even found that DPP-4 inhibitors are associated loosely statistically with a higher incidence of thyroid cancers, which again just raises questions to me whether these are uh, valid and reproducible results. I'll move on in order to illustrate my point, if that's okay with you. I'm going to move on to another study from the US now of 300,000 patients with type 2 diabetes at moderate risk for cardiovascular disease who were given GLP-1 based medication. So I want to illustrate this point to you. But what they identified in this study was that the higher incidence of thyroid cancer here was only observed in the first year of exposure to the medications. But as years progressed, and as the exposure to the medication progressed, the incidence of cancer reduced, and actually there was no difference compared to a control group. This doesn't make sense from a physiological and clinical perspective. Why would a medication, which is GLP-1 based, develop cause cancer in 1 year, in the first year of exposure, and not subsequently? And I think the answer to that question, to that puzzling question, comes from the graph here, which demonstrates again this perhaps preoccupation and fear of physicians with regards to potential risks of any of those medications that lead them to request a lot of investigations, a lot of ultrasonography for these patients. You see how significantly higher the rates of ultrasonography are for people that are on GLP-1 receptor treatments compared to populations that are not. So basically, we are just discovering more cancers because we are looking for more cancers in this population. If we were looking for more cancers in populations that are not GLP-1 treated, I think we would find something very similar. However, I think that this is all a combination of statistical issues, but also clinical practice that leads to overinflation of these figures. I'll take you through a couple more slides that I think are probably more reassuring. This is a study from the UK, which compared the incidence of thyroid cancer in people who were started on GLP-1 receptor medications. This was one group here, and they were matched to a population that of again people that were started on DPP-4 inhibitors. So this was a comparison between these two medication classes. These were all people with type 2 diabetes, and based on the evidence from a community care database that we have in the UK, they looked at the incidence of thyroid cancer over the course of 10 years. And reassuringly, you see from those graphs that there is no difference between GLP-1 receptor agonists and DPP-4 inhibitors in the incidence of thyroid cancer over the course of 10 years. I think that this is reasonably reassuring. What you'll also notice is that the incidence of thyroid cancer again remains very, very low. You're looking at something like 0.15% over the course of 10 years, which is much more similar to the American study that I have just shown you. And I think, again, it is much more likely to be valid and help us with our interpretation. The good news is that the European Medicines Agency in 2023 published a report all of the available data for thyroid cancer, and I here have got the actual screenshot of the recommendation, which was that when it comes to exenatide, liraglutide, dulaglutide, semaglutide, and lixisenatide, there was no risk associated with cancer of the thyroid through the use of this medication. I would be surprised if any other GLP-1 medication has a different profile to what I have just described. So I would consider that quite reassuring. So what I would like to say, and I would also like to hear your thoughts from your clinical practice, is that I still, of course, do not start this medication in people who have got medullary thyroid cancer, either personal history or family history. But if anyone that sees me in my clinic has benign thyroid nodules, I start the medication. If someone in my clinic has had a previous history of follicular or papillary thyroid cancer, different forms of medullary, medullary thyroid cancer, I still start the medication. And more importantly, when I treat my patients, I don't look for uh, trouble. I don't do ultrasonography of the thyroid unless they develop symptoms. So that's a completely different matter. But I want to hear how your practice may be similar or different to mine.
Yeah, I would tend to agree with that. And indeed, over the last few years, we have kept our radiologists extremely busy unnecessarily with all these extra tests that we've been ordering, which are, as the data suggests, not really necessary. So yes, I too stick to the recommendations for NEN, and anybody who has just a simple benign thyroid nodule, if it is that they warrant to be on the medication and they would benefit from the medication, we explain that to them, and they can start it. There's no need to scare the patients about this risk for cancer, as we've seen from the large epidemiological data, that they're quite safe, and so hopefully we can at least lay down this myth to rest, that there isn't a correlation between exposure to injectable GLP-1 receptor agonists and the risk for thyroid cancer. So,
if I can interrupt, Dr. Khalid, if you don't mind, I'll just finish off with one point,
yes,
and
please go ahead.
you may have experience with that as well, which is that I have conducted some of the commercial clinical trials for some of those GLP-1 receptor medications. And in the clinical trials, we are obliged to also measure calcitonin,
Yes.
not only before, but also throughout the treatment. And what I have uh, realized over the years is that the rises in calcitonin do not translate in the patients that I have experience with, do not translate to anything sinister when it comes to the thyroid. They cause a lot of anxiety, a lot of extra work, and I haven't picked up any thyroid cancers through the monitoring with calcitonin. So along the same lines of not doing ultrasound for my patients if there are no symptoms, I also don't measure calcitonin. Sorry to interrupt.
Right, right. And there are no recommendations for doing so, absolutely. So, from cancer risk to mental health, and there have been, of course, these reports on suicidal ideation and self harm. So, what are your thoughts on, this? Is there really a signal? Is there an association between GLP-1 receptor use and suicidal ideation? Have you come across, any such cases?
Yeah, so I'll start by saying that, as you know, in all of the randomized trials in GLP-1 receptor medication, both in people with diabetes and people with obesity, there has not been a signal of suicidal ideation because of the medications. And also, in general, the quality of life of people improves. Okay. Let me take you through some of the data that have again raised some concerns. They're all relatively recent. This is a publication from 2024 from the WHO global database of suspected adverse drug reactions. So that is a huge database. And basically, to explain to you the way that this works is that they compare one drug to the rest of the drugs in their field or even in different fields of medicine. And they see, is there a disproportionate signal? That's what they call here disproportionality analysis. Is there a disproportionate signal of something going wrong with one medication versus all the others that they're comparing to? And what you see from this database is the only finding that I can see of any significance is this rise of 45% in suicidal ideation with semaglutide, but not with liraglutide. Let me go through some of the potential weaknesses of these comparisons. Again, notoriety bias comes into force, which means that if because of our bad experience, because we got burned in the past, suicidal ideation in suicides themselves with previous class of these obesity medications, we are hyper alert. So we're much more likely to report them compared to other medications that we use in medicine that we don't think are associated with suicidal ideation. And again, this artificially inflates the number. To give you an idea as to how this works, if you read this part of the interpretation, all adverse drug reactions associated with the semaglutide between 2022 to 2023 were increased by 36%. I'm talking about GI side effects. Yet, the adverse drug reaction when it comes to suicidal ideation was increased by 706%. That demonstrates this over-reporting and over-inflation numbers. And so we need to be careful when we are analyzing this type of disproportionality analysis because the method, the model that we use makes a big difference. Let's move on to some additional data that has come into light in the last 12 months. These are data from Dana Small, published in Nature Medicine, where she compared uh, the 250,000 patients with obesity now who were prescribed semaglutide versus obesity medications that were not GLP-1 receptor based, any other class. And what she found, if you focus your eyes on this part of the slide, she actually did not find an increase. She actually found a reduction in suicidal ideation by a very large margin of about 70% or so. So, again, I think this is reassuring, and the comparison with other medications in the field again provides a little bit more confidence in the use of the GLP-1 based medication. Let's move on to the same study that I described to you about thyroid cancer previously, that the one that was done in the UK, and now use it to start to answer this question, the question about suicidal ideation, self-harm, and suicide. And this was a comparison, as we said, of people that were started on GLP-1 receptor treatments. There were people that were started on DPP-4 inhibitors that I think we will all agree DPP-4 inhibitors are not associated with a higher risk of suicidal ideation. And again, during a follow-up of 10 years, you're going to see that there was no statistically significant difference between the two classes of medications. Again, this is reassuring, and as I mentioned earlier on, these are in people with type 2 diabetes. These are the type of data that I am more likely to believe. These are data This is a meta-analysis, as you will see, of a very large number, 27 randomized controlled clinical trials lasting 6 months or more, that were comparing GLP-1 agonist medications versus placebo for different indications, for diabetes, glycemic control, weight loss, cardiovascular risk factors, cardiovascular outcomes. This is the forest plot for diabetes, people with diabetes, and this is the forest plot for people with obesity without diabetes. As you see, the diamond crosses the line, which means that there is no hint of an increase in the incidence of suicide or self-harm with these medications in these randomized trials. In fact, you see the diamond is towards the side of potential benefit. Okay, so I would consider that type of data very, very reassuring. But let me just say something that again you probably know from your own practice, and again I would like to hear your thoughts, which is that uh, I always like to parallel our our findings and our observations now with what we've known, as I said to you previously, for the last 60 years, that we've been using bariatric surgery for obesity. And we know that there is a very, very small number of people in whom weight loss will cause some psychological disturbance. Even though the big numbers, the big proportions of the population, they will benefit with good quality of life and good improvements in the anxiety, depression, etc. There's always a very small number of people who may react paradoxically badly to weight loss through this medication. So we know from bariatric surgery that there is an increase of suicide, even though the absolute risks are very, very low. So I wouldn't be surprised if over the next 5 or 10 years, we do identify people who react adversely, a small number of people who react adversely to this medication. We don't exactly know the cause of that, but we think that it has to do with these medications removing food from people's lives, the pleasure of food from people's lives, and the soothing effect of food in terms of stress and emotion. This is a functional MRI slide that I'm throwing there, a study that we did a number of years ago, and where we saw that the reward areas of the brain after gastric bypass surgery light up significantly less when people are looking at high calorie foods compared to other forms of bariatric surgery like the gastric band. And that we're seeing similar results with these medications. And again, they demonstrate that if we do remove this emotional regulating substance, i.e., food from people's lives, a small number may react badly. But the good news about medication is that if we do detect behaviors like that, we can always stop the medication. With bariatric surgery, we have got something which is pretty much irreversible in many situations, and we're a little bit stuck. And I will finish off this part of the discussion again, going back to the Europeans and the European Medicines Agency uh, conclusion uh, on an investigation that they run again for the same GLP-1 based medications that we discussed previously, but this time they were looking at suicidal and self-injuries, thought and actions, and they did not find a link between the medications and that. And this is again a screenshot from the report in 2024.
Right. Yeah. I would absolutely tend to agree with that. And in fact, from what we've seen in clinical practice, is that most patients actually improve in terms of their quality of life. But what you highlighted is really important because patients who are managed uh, for weight management really needs to be in sort of a multidisciplinary setting whereby a psychologist, should be part of the team, just as we have, the clinical nutritionists and of course the physicians. And when we do identify that patients have any sort of mental disorders, we're able to support them with your therapy. So maybe we can, reduce this number of patients that may be prone to this sort of behavior when you remove the hedonic pleasure of food. We can identify them early when they're managed in this sort of multidisciplinary setting. Um, Yeah, that was very reassuring, and I hope your audience take from this as well that there is no increased risk for any sort of suicidal ideation or self harm with the use of GLP-1 receptor agonists. And from there on, maybe we can move on to another topic which recently has also caught our attention, and that has been through some case reports about non-arteritic anterior ischemic optic neuropathy. And is this something as well that we need to be concerned about with the use of an exposure to GLP-1 receptor agonists?
To be honest with you, before I heard the reports about the link, the potential between the medications and this eye complication, I had never heard of it before. So I really have to look into the pathophysiology of this. I must say, I have never had any exposure.
It did come as a big surprise, actually, yes.
Yeah, I just didn't even know what it was. So anyway, here it is. So this is a slide that demonstrates the pathophysiology. And basically, again, it's a perfusion issue, but of the small ciliary branches. Therefore, it can happen in people that have got microvascular disease, people with diabetes, for example, and it causes ischemia, small vessel ischemia around the disc, around the optic disc. And what happens here, which is where the optic disc enters the retina, is that this ischemia causes inflammation, causes swelling, and it is that swelling that and the pressure that causes this neuropathy. So well recognized in diabetes. I'm not sure how well it is recognized in obesity, but certainly in people with cardiovascular, both macro and microvascular disease, well recognized. And most of the concern came from this case series. This was 7 people that were treated in a community setting, and they were identified as developing here optic nerve swelling. You will see that they all had that, or most of them had diabetes. So that generated some interest into this potential link. And subsequently, there was again a case series that was matched to a control. Let me take you through this. So this was a retrospective matched control study from a data again registry of patients evaluated by neuro-ophthalmologists. So they took people that have had this condition and they propensity matched them with those that did take semaglutide for diabetes and or obesity. What you'll see here, these are the results for type 2 diabetes. And you'll notice, even though the graph goes down, it basically means that the use of semaglutide was associated with the higher risk of developing this condition, and exactly the same outcomes when semaglutide was given in people with overweight or obesity. This is probably the publication that generated most of the concern. Some limitations in the way that we should interpret the data. First of all, you will notice that the two curves separate very early, which physiologically and clinically doesn't make a huge amount of sense. Why would, even after days or weeks of using this medication, suddenly people start developing this vascular complication? So that raises some suspicions as to whether this is true or not. Even if it is true, the reason why we're seeing this difference between the groups is because we are much more likely to give these medications to people that are sicker than others. So people who are more advanced in their diabetes. more advanced into the obesity and into the journey of microvascular complications. Therefore, this may just reflect the use of these medications in sicker patients rather than, again, a real finding, which may, again, exaggerate some of the numbers that you're seeing there. In fact, there was no exclusion in this cohort of people that you're seeing in this study. There was no exclusion of optic neuropathy before they took part in the study. So we don't know whether they had it before or whether they had subclinical disease, etc. So because there was no exclusion, again, I would like to say that number one, the incidence of this complication is very, very, very low. It's very rare. And I would question if the link is with the use of the medications or whether the link is because we are treating sicker population with these medications. But as I always say, it doesn't mean that when something comes into in the limelight that we don't believe, we should dismiss it. So what I would say is let's keep an open mind. Okay. At the moment, I am not concerned, and at the moment when I am counseling patients for the use of these medications, I don't mention these rare complications. However, if people report to me changes in their vision, then I I will have a lower threshold for getting them examined by an ophthalmologist. So I'm keeping an open mind, and I'm saying that time will tell. But at the moment, I am not uh, concerned about this enough to counsel patients. I don't know what your practice is.
So for the patients with type 2 diabetes that require to take the GLP-1 based therapies, I just follow their standards of care, the recommendations about their retinopathy screening and so on.